My name is Terry King. I'm the Chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Brigham and Women's Cancer Center. So the use of neoadjuvant endocrine therapy is gaining popularity in the United States based on several studies that have now shown amongst postmenopausal breast cancer patients with hormone receptor positive disease that downstaging for breast conservation is very doable with neoadjuvant endocrine therapy. And in fact, it may be easier with neoadjuvant endocrine therapy than with neoadjuvant chemotherapy, but with much less toxicity. Of course, neoadjuvant endocrine therapy is easier for patients to tolerate than neoadjuvant chemotherapy. And so although we have many studies such as ACOSOG, Z1031 and other trials from Europe demonstrating the utility of neoadjuvant endocrine therapy in downstaging to achieve breast conservation, there's been much less focus on standardized management of the axilla after neoadjuvant endocrine therapy. And in fact, there really are no evidence-based guidelines for management of the axilla after neoadjuvant endocrine therapy. Now, many institutions and surgeons have been extrapolating the guidelines for management of the axilla after neoadjuvant chemotherapy to the neoadjuvant endocrine therapy population. But our hypothesis is that this may not be the right approach. Again, patient selection for neoadjuvant chemotherapy versus neoadjuvant endocrine therapy is much different. In hormone receptor positive HER2 negative disease, we don't expect high rates of PCR either in the breast or the lymph nodes with neoadjuvant endocrine therapy. And in many of these hormone receptor positive HER2 negative patients, if they would go to upfront surgery, they would be eligible for management according to ACOSOG Z11 or AMROS, where we know in patients that have 1 to 2 positive nodes that they do not benefit from additional lymph node dissection, or perhaps additional lymph node dissection could be omitted in favor of axillary radiotherapy. So when we select a patient for neoadjuvant endocrine therapy, our approach has been to try to identify women who have a low volume of nodal disease prior to starting that neoadjuvant endocrine therapy in the hopes of being able to offer them sentinel node biopsy after neoadjuvant endocrine therapy. And in women who have only 1 or 2 positive sentinel nodes, then applying those strategies used in the upfront surgical setting, again, because we know that we don't expect a nodal PCR from neoadjuvant endocrine therapy, and we know that the preoperative use of endocrine therapy is only a small fraction of the total course of endocrine therapy that patient is going to receive. So when we select patients for neoadjuvant endocrine therapy, we do perform ultrasound of the axilla pre-treatment, looking for those potential patients that we might be surprised and they have a high volume of nodal disease. We really want to identify patients who have only 1 or 2 abnormal looking nodes, if there are any abnormal looking nodes. And again, we biopsy any abnormal looking nodes and we do place clips in them. In our women that have either negative looking nodes on ultrasound or only 1 or 2 abnormal looking nodes on ultrasound, they're treated with neoadjuvant endocrine therapy, and at the completion of neoadjuvant endocrine therapy, we are offering them sentinel lymph node biopsy in the same manner that we perform after neoadjuvant chemotherapy. But in this setting, in our patients who are found to have only 1 or 2 positive nodes, we do not perform a completion axillary node dissection. We treat them either with the Z11 approach of observation of the axilla, or we treat them with the AMROS approach of radiation to the axilla, again, depending on whether they've had breast conservation therapy, depending on their other features of their tumor and what their total tumor burden is, So we are really trying to tailor our strategies for management of the axilla after neoadjuvant chemotherapy and refine these approaches as opposed to just applying neoadjuvant chemotherapy strategies. Again, coming back to the point that patients selected for neoadjuvant endocrine therapy are different than patients selected for neoadjuvant chemotherapy. The biology of hormone receptor positive HER2 negative breast cancers tells us that we don't expect high rates of PCR either in the breast or in the axilla. If we're using neoadjuvant chemotherapy to downstage the tumor in the breast, which we know it does very well, we don't want to overtreat the axilla simply because we used neoadjuvant endocrine therapy to downstage the breast. So we're looking for patients with low volume disease in the hopes of applying the upfront surgery strategies to that group. Our group has done work in this area. We've published some reports from the NCDB showing the rates of completion axillary node dissection after neoadjuvant endocrine therapy in the population reported to the NCDB. And it seems like surgeons are also dialing back. We do not see nearly the same rates of completion axillary node dissection being performed after neoadjuvant endocrine therapy, even in women with node-positive disease. Now, of course, we don't know all the factors that go into those decisions when we look at a population-based database like the NCDB, but we have looked at the outcomes in the NCDB, and it does not appear that women who omit completion axillary node dissection, it does not appear that they have inferior survival compared to those that do. Again, a lot of selection bias in the NCDB, but a signal that perhaps residual disease in the nodes after neoadjuvant endocrine therapy may not carry the same prognostic significance as residual disease in the nodes after neoadjuvant chemotherapy. And again, in the neoadjuvant endocrine therapy approach, those patients have only received a small portion of the overall endocrine treatment that they will continue to receive after surgery. And so we really do think this is an opportunity to refine these strategies for the neoadjuvant endocrine therapy population and try to move this particular question forward.